Welcome to the Behind the Sports Medicine podcast, proudly sponsored by AJR Sports Science and Healthcare Consulting. At AJR, we're committed to offering a comprehensive range of exceptional services, including applied sports science analytics, healthcare and sports medicine consulting, and leadership and coaching development. To learn more about AJR, visit their website at ajrsportscience.com. I'm Andrew Rizza, your host and an allied healthcare professional with over 25 years of experience. My career has primarily spanned private physical therapy and public school athletics. Driven by curiosity and a passion for the industry, I created the Behind the Sports Medicine podcast to explore the ever-evolving landscape of healthcare with a focus on sports medicine, physical therapy, athletic training, and sports science.
And I'm your co-host, Cameron Roth, a hand and upper extremity surgeon based in Phoenix, Arizona. Outside of the office, I serve as a peer reviewer for the Journal of Hand Surgery and a consultant for Major League Baseball's Chicago White Sox. I'm excited to join my close friend and mentor, Andrew Rizza, a.k.a. Riz, in exploring all facets of sports medicine, including surgery, rehabilitation, mindset, and much more. In each episode, we'll delve into various topics such as surgery and rehab, prevention, mindset, and innovations into sports science. Join us as we embark on this journey to uncover the intricacies of sports medicine and provide valuable insights to professionals, athletes, and enthusiasts alike.
Hey, everybody. Welcome to this week's Behind the Sports Medicine podcast. This week, I have Dr. J.P. Warner from Boston, Mass General Hospital. Dr. Warner and I have known each other for quite a long time. I've taken care of his children with injuries, but also he sent a lot of patients to us over the years. I've taken care of his shoulder patients that have sent over to PT. And also our co-host, Cameron Roth, is here.
Very, very excited. I grew up with Dr. Warner's kids. He's been a mentor to me for probably over 15 years, been incredibly gracious and having me in his clinic and meeting with me over the years. And it's just awesome to get to talk and continue to learn from him. So thanks for being here.
Pleasure.
Dr. Warner, can you just give a brief bio, just a little bit more to the people that are listening about yourself and what you do with your practice?
Yeah, let me sort of work backwards. I'm currently emeritus chief of the shoulder service at Mass General Hospital, a service that I founded in 1998 when I came here. Also the founder of the Boston Shoulder Institute, which is our value-based arm, which is a patient portal to explain to patients using explanations that are appropriate to a consumer who's not a doctor. And most importantly, it is a portal for measurement and transparency. So every year we report everything we do, and we report our outcomes from the standpoint of any complications, so that when I talk with patients, we can explain to them what options they have available for their treatment and what the risk-benefit is for each of these. And moreover, the process of recovery. That's been something I'm very proud of. I'm also the founder of the Codman Shoulder Society, which honors Ernest A. Codman, who was, I guess, my predecessor at Mass General Hospital more than 100 years ago. He wrote the first book in English on the shoulder and created the anesthesia record as well as many other things. And he was a champion of value-based healthcare, which is something I try to aspire to, and a variety of other things, including New England Shoulder Elbow Society. I'm a professor at Harvard Business School. I don't know how many articles I've published. I stopped counting, or how many lectures I've given or any of that. I'm not in the resume phase anymore. I'm in the legacy phase.
That's good.
I've already hired my replacement. I'm just sticking around until I don't feel like sticking around. Historically, in terms of bio, I was a resident at Harvard, at the Harvard Combined Orthopedic Program. Subsequent to that, I graduated from Harvard Business School. Before that, University of Rochester School of Medicine, where I also did a surgery residency, traveling fellowships at Hospital for Special Surgery, the University of Bern in Switzerland, University of Paris in France, and the University of Linköping, which is in Sweden near Stockholm, to name a few. And then I wasn't going to go all the way back. I'm not going to go back to stop there. I'm going to stop at college and high school and the rest of that stuff.
Yeah, that's a very lengthy and very well rounded resume, I would have to say. And you know, I look back to when we first met, and just to look at back then what you'd accomplished and the ability that we had to have access to you has been amazing. And then to use you, I mean, I consider you as being, to me, like Cameron said, a mentor, because I can always, reach out if there was something that we needed for a patient or had a question. And you were very gracious in being able to offer that, knowledge base to us. And it's been amazing. And patients, I always tell them when there's something going wrong with their shoulder, if they had a repair done, they say, who should I go to? I said, the only guy I would go to would be you if something got screwed up, right? So I think that was always good to know that if we needed something to be revised or something that wasn't working, or even somebody that was in their first stage, it was pointing them to you because we knew that you were going to do the great job that you do.
Let me just make a comment on that, since this is a podcast, and I guess I can cut in a little bit. First of all, it's a privilege. Second of all, one thing I'm most proud of, other than my children and some of the things I've done outside the institution, was the creation of the New England Shoulder Elbow Society and a group interested in treating shoulder problems. So New England has a lot of very competent shoulder surgeons. Some are transplants from elsewhere, trained elsewhere, and decided to live here. But New England Shoulder Elbow Society last year, I think, had over 200 people attend its annual meeting, and more than that at the banquet. And that is now 20, 21 years, something like that. And that brings people together to discuss how best to treat problems as they relate to the shoulder and elbow as well. And that benefits everyone in New England. So it's nice of you to say that I'm the guy that you want to send people to, but I told you I was in my legacy phase, and there's a lot of people here that I helped train, and even others that I've just helped, that function at a very, very high level. Case in point, we do regularly get referrals from New York. Talk about why, but that's, I think, really nice because that never happened before. Everything flowed towards the big city. Now some of it can flow out to the experts that are in New England, and it's not just me. It's actually many people that are here now that will carry on with that skill set.
Yeah, that's great. That's great. Cam, anything to add there since you've had the ability to be able to use
No,
Dr. Warner to your devices?
I would agree. I mean, did my fellowship at the Brigham, and I've met all the younger shoulder surgeons in the Brigham and MGH system who have either trained with you or worked with you, and it's an incredible expanding network. But really, anywhere you go now that I'm based in Phoenix, anywhere you go, if you talk about New England or shoulder surgery in general, your name's always at the top of the list. And I've read most of your papers over the past 5 to 7 years. So the network continues to expand, but we're very lucky to have close information, close access. So it's great.
Riz, let me put a little bit of context here. It's nice to be, on the short list and everything, but when that happens. That happens when you're in your sweet spot in life, not something which neither of you know about. You know what the sweet spot is? Everything goes like this, and like that. Life isn't just, life is sinusoidal. So the sweet spot is when you have enough wisdom that people think you have something to offer them, but you're not yet senile. That's where I am at the moment. So I appreciate the compliments, but I'm the only scaling you do this is when you leave people behind you who build on what you gave them. So thanks for the compliment, but that's really my biggest accomplishment.
That's fantastic. Looking into, I think the big thing that I think a lot of people ask us in the physical therapy world and the athletic training world, when a rotator cuff repair is needed, is there a discussion on open versus closed repair? When do you ever make that decision with somebody, and does that conversation come up given the population you see?
So let me start back when I first trained in my fellowship and went into practice. In those days, everything was open.
Mm-hmm.
In fact, in the late 80s, early 90s, arthroscopy was just gaining a foothold. We didn't have any tools or skill set to do rotator cuff repair arthroscopically. Flash forward to now, and most of the fellows I train don't know how to do open rotator cuff repair. As a consequence, patients have no clue that there's anything but arthroscopic repair. Now, there are very few instances where open repair is indicated, and I can expand on arthroscopic repair and all of that. I want to just, before I get to that, I want to emphasize that there has never been a good prospective randomized study, which would be impossible to do, between open and arthroscopic, because no patient would want to sign up for, I want a big incision or a little incision, okay? That said, there are a few clear observations that I can make here. Number one, there is no difference in the magnitude of pain people feel with an arthroscopic repair or an open repair. That's an important thing because you studied that and published it. Number two, arthroscopic repair offers the ability to see inside the shoulder, like by going through a keyhole and walking around in the room. Open repair requires you to make a bigger incision to see things. Now, in some instances, particularly revision surgery, an open repair is appropriate when you're going to do something other than try to fix a tendon, like a tendon transfer or some other thing, which is the minority of things that we do. Arthroscopic repair is very routine now, and I can't remember the exact number, but gosh, it's over 1 million, I think 1 million patients maybe having rotator cuff repairs, annually. So it's one of the top 5 reasons why people see a primary care doctor in terms of their shoulder rotator cuff, and it's one of the major reasons for loss of days at work. So virtually the majority of these are done arthroscopically, or perhaps arthroscopic assisted when you have to do something more than a simple rotator cuff repair. Point being that our skill sets now in people who have trained to do arthroscopy and know how to do it, doing arthroscopic repair is no less good than doing open repair in terms of what you can see, what you can do, how you can assess. And perhaps it's a lower infection rate because fluid's flowing in and out. And so infections with arthroscopic repair are extremely low. Maybe not so in open repair, although still very low, but magnitude of order lower with arthroscopic repair. Sorry to run away with that topic, but I wanted to put it some context.
It was a great explanation. The one question that always comes up, if somebody has a partial tear versus a full thickness, they're like, well, some people say I don't need to have a rotator cuff repair because I can do strengthening through therapy.
Yeah, I would just say I spent some time with Ralph Hertel in Bern, and he still does open rotator cuff repairs. And obviously you have significant international experience and know all those guys. And it seems that arthroscopy, the push towards continued arthroscopy, not just rotator cuff repair, but really everything, especially with your partner, Dr. El Hassan, is more of an American phenomenon. And maybe internationally, they are still obviously doing arthroscopy, but the threshold to do open rotator cuff repair may be lower.
So let me address that. First of all, pause for a minute. You mentioned partial repair.
Yeah.
Partial tear, partial rotator cuff tear. So I want to share with you, I want to share in context. We operate on people who have symptoms, not on MRIs.
Yep.
I could care less if an MRI shows a partial tear and someone says, I play tennis, I feel great, thanks a lot. In fact, if you look, you know this, if you look at enough MRIs of baseball players, they're throwing the ball at high speed and doing other things, and their rotator cuffs don't look normal. More importantly, the false positive rate of a radiologist saying someone has rotator cuff pathology in studies that have been done looking at people who are normal, quote unquote normal, is 30%. Okay? So when someone comes to me with an MRI that says partial rotator cuff tear, I take that with a grain of salt because it has to be put in context of the symptoms in the exam and etc. Symptomatic partial rotator cuff tears are typically, but not always, bursal side tears, which are a phenomenon from mechanical impingement and are very painful. Now, articular-sided tears happen, and there's a lot of biomechanics to this, typically from overloading of the rotator cuff, and they're symptomatic in varying degrees. The rotator cuff doesn't just boom tear. It starts out as something. And it starts out as some pathology. Tendons which tear are never normal. So what tore was already degenerating, maybe without symptoms. So I want to make sure we're clear on that. The other point about European versus US and etc., there's no question the US pioneered, with the exception of perhaps maybe Asian surgeons, the US pioneered arthroscopic techniques. I mean, there's so many. Felsenreich was a Swiss surgeon, I believe. He developed early arthroscopy. Watanabe, many others. Watanabe was in Japan, of course. So it's not like it all started here. However, it was commercialized in the U.S. And I might add, it's scaled in the U.S. And the indications have become lower for doing arthroscopy because arthroscopy is so easy to do. Why don't we just take a look, kind of an approach, rather than why don't we do conservative and this and that and et cetera. Let me just put this in context for the economics that we live in currently. In the fee-for-service environment, or the RVU environment where physicians are paid in RVUs, there is an incentive to lower your indications and increase your number of cases to compensate for the lower payments for service. I'm sorry, but it's just how I see it, because I see a lot of people that have surgery that's not so ideal, and I'm sure you do as well. because physiotherapy helps a lot of people get better, but you have to pick the right people. And so when we start talking about partial repairs and open and arthroscopic, I think we can't get on that topic until we talk about proper treatment, which includes non-operative versus operative, to give some context to this, okay? And then the open part of it is, I know Ralph Hertel very well. In fact, I met him in 1988 when I was a traveling fellow in Bern, when he was a so-called Oberarzt, which is like a chief resident. And he's a very, very skilled surgeon. And if he does open surgery, he does it for a very specific reason, which I'm not sure I know exactly. He may do arthroscopic and open in some circumstances. But we have to be careful to generalize what individuals do. There's no question patients want arthroscopic surgery, and the companies that make the products want you to do arthroscopic surgery as a surgeon. The more the better, because anchors cost a lot of money. And one last point I want to make is, and that is the economics of rotator cuff repair. We've now done 2 studies. One, we looked at 720 rotator cuff repairs at Mass General Brigham and the costs associated with those. And the other, we did a multi-center study with Avant-Garde Health, a healthcare data analytics company. I looked at even more. I can't remember the exact number, to look at the cost. And in our own center here, Mass General Brigham, the variation among how many, 18 surgeons or something like that, for the cost of a rotator cuff repair was a factor of 7 or 8 times. Why would that be? Because rotator cuff tears come in different shapes and sizes. They come with different requirements. There's all sorts of high-cost tools like grafts and tendon transfers, and anchors vary in their cost. And surgeons love to try to fix things. Mm-hmm. And you can't talk about rotator cuff repair unless you talk about the factors that push people to do them and the outcomes of those. And the point being, it's an extremely heterogeneous population of conditions, most of which don't need surgery.
And I'm glad you started with, symptoms in biomechanics, because the first thing we speak about when a patient gets referred to us is, let's try PT first, right? We know that if you're asymptomatic, if we can get your biomechanics and your kinematics back to where it needs to be, and you're fully functional in your activities of daily living, then there really isn't need to do anything. And then if we fail in 6 to 8 weeks down the road, that patient isn't any better, we're referring right back to you, the surgeon, to make a decision and have a conversation with that patient. So I think that was a great kind of segue to discuss that and to understand, for the person that's listening that doesn't understand what we see as therapists or as physicians, what we're looking at, and then we're not quick to say, hey, you know what, you need surgery because the MRI shows.
Right. I think as well, there are instances that do need surgery, like someone who has a traumatic injury, falls down, can't raise their arm.
No, 100%, yeah.
Okay. But there are all sorts of factors that we look at, and degenerative rotator cuff tears in a 60 plus, 70 plus individual. My shoulder hurts. It's been bothering me a long time. My MRI shows a rotator cuff tear. Jed Kuhn and the Moon Group, which is a multi-center study group, and many other studies done on other continents have clearly demonstrated that the majority of patients who do physiotherapy get better without the need for surgery. That must be differentiated from those that have either had a trauma or have already failed therapy. And is it pain? Is it weakness? What is it? Are as valuable as anything else before you're deciding, well, I'm going to take you to the operating room and fix something.
Yeah. Yeah. The question on revisions. I know this is like kind of a loaded question, I think, because as you talked about repairs, if someone does have a failed repair, obviously you're looking at tissue quality, you're looking at function, you're looking at all the other factors we talked about. How do you approach that with a patient? If someone comes in and says, hey, listen, I've had 2 rotator cuffs that have failed, what's the discussion? How does that person then go through the processes of getting themselves fully functional again? Is there a discussion on trapezius transfers? Is there discussions on, hey, you might be someone that needs a replacement?
So let me just say, there are additional resources that viewers can go to, be they YouTube or ViewMedi, which is a wonderful repository for videos, over 60,000 videos available in different areas. But what you just asked, a lot of this is answered in those videos. So for anybody watching this who is a healthcare provider or working for industry, it's free. Join. And then you can access. There's so many videos, it's a little hard to search, but I'm going to give a Grand Rounds lecture tomorrow for Lenox Hill, remote. on factors which help me decide on alternatives to shoulder replacement or reverse replacement for irreparable rotator cuff tears. That includes a lot of what you talked about, tendon transfers, etc. And there's many, many versions of this, and many people have lectured on this, and etc. I also want to emphasize that when you go look at these videos, remember the wisdom of a guy named Christian Gerber, a teacher of mine, who said to me, if two people agree, one is not a surgeon. Don't look for agreement here, okay? But to come back to your question, number one, what are the symptoms? What are the expectations? Is it pain? Is it weakness? Is it both? What is it that you want to do? Can you not sleep? You know, they're basic things. When you have pain that interferes with your daily life, you can't do your job, you can't sleep, you can't do the things you enjoy. That's a lot different than I can't hit a great tennis serve or whatever. Okay. Then there are patient factors for realistic. Are they older? Do they have diabetes? Do they have a history of smoking? These are intrinsic patient factors that are relevant to healing if you're going to undertake to do a repair. And there are many more. There are tissue factors as well. So when we look at them, assuming there's no X-ray changes of arthritis or anything like that, what is the characteristic, not just of the tendon, but this is also a muscle disease. When a tendon fails chronically, there are physiologic changes that happen at the ultrastructural level in a muscle. So between the sarcomeres, there's infiltration of fat and scar. Why does that happen? It's believed that happens because when the tendon tears and the muscle retracts, there's space between the fibers, the sarcomere fibers, and fat and scar infiltrate. And so you lose the compliance of the muscle unit. So the muscle has to generate power across an amplitude, right? So that's the Blix curve. So the ability of the muscle to generate power anyway changes over time. And so when we look at an MRI, we're also looking at muscle. And classification is according to a Frenchman named Latarjet, who described by CT scan, which what we now do on MRI, are grades of fatty atrophy, 1, 2, 3, 4, etc. Now, why is that relevant? Without giving a lot of references, if you look at an MRI and you see the tendon is less than 15 millimeters in length, not out of the blue, it's a study that was done, and the fatty atrophy is greater than 2+, meaning it's more fat than muscle. If you repair that tendon, and then you'll get an MRI on it after surgery, it has a re-tear rate of 90% plus. So, these are attritional changes that change the calculus for why even bother trying to fix that. So those are tissue factors. And then there are bony factors. Is there disuse osteopenia? Because if you're going to put an anchor in an elderly individual, the bone can be poor quality as well because of Wolff's law. No tendon pulling on it, it becomes osteopenic. And now you're putting anchors and sutures into something that is osteopenic. And so there are ways to deal with that as well. So these are the kinds of things I look at. If you get into the category of revision surgery, is it repairable? Is it not repairable? What's the healing potential for it? And that gets into really the gigantic controversy of, is there a role for tissue augmentation or stem cells, God forbid? And here are all of that superior capsular reconstruction known as SCR, before we even talk about dynamic solutions such as tendon transfers, or even more recently, the expensive device called the in-space balloon, which creates a artificial mechanical substitute for the effective biomechanical effectiveness of the rotator cuff. So I'm sorry to give you a buffet or smorgasbord of answer here, but this is what we see when the people come in with failed rotator cuffs and how I look at it, basically.
I mean, that's an unbelievable explanation. If anything that anybody gets out of this, they just got a great anatomy lesson. But Cam, I think, had a question about the balloon. We were talking about this yesterday, so...
Well, the buffet you presented us is actually all the options I had written down for this question that Riz asked you. So, when you go to talks, every shoulder surgeon puts up their own algorithm for what to do for massive irreparable cuff tears. And in my notes, I probably have 10 separate shoulder surgeons, different algorithms, and some of them are similar and some of them are different. But you have some big proponents of the balloon, and then some people who say the indications are none. I've actually never seen it in use besides videos on ViewMedi, and I've never used it myself. Have you ever used it, or what is your,
So,
I would love to hear your opinion.
So conflict of interest disclosure. I was a scientific officer for Orthospace. So I helped them do all the FDA study to get it approved. I owned equity. I have no interest in it now that Stryker's acquired it, but it was in my interest to put it through now to get it approved. Now, just to be clear, when the FDA approved something like this, they required a 2-arm study. So this was partial repair versus the balloon and a 2-year minimum follow-up. And what we identified was, and all we needed to identify was, as good as. So if you did a partial repair, that meant you repaired what of the rotator cuff was left to repair, or you used the balloon. Patients did surprisingly well in both categories. Okay, we haven't even talked about partial repair, not full repair. So the difference with the balloon is that it creates for people who don't understand what it is, you insert this absorbable material that is inflated with saline, and it creates this hydrostatic effect that basically creates a buffer or bumper to the humeral head that keeps it centered. So there's a fulcrum for rotation to raise the arm over the head. Mm-hmm. And since that balloon has come into the marketplace, it's generated certainly more than what the company paid for it. Now, the problem with it is it's very expensive. So the other question is, because it resorbs, it goes away, it's gone after, oh gosh, I don't know, I forget the number, 3 months or something like that. How does it keep working? Mm-hmm. And nobody really knows it, and the FDA didn't require that. My feeling is that it's sort of an internal mechanical training tool that lets the muscles learn how to coordinate and function for better advantage. And when we do physiotherapy, Riz, we're recruiting the muscles that remain attached in the rotator cuff to compensate for those that are gone. And that's what the balloon probably makes easier, okay? So I put in one, okay? Why? Because my hospital, try to limit what I can put in terms of cost. That patient was unbelievable at 7 weeks, rowing her shell, dancing around. You couldn't tell which arm had been operated. Now, 3 or 4 months later, oh, it hurts. Still good motion. It hurts, but I can't do what I want to do. Now, is that because the patient had unrealistic expectations or what? I don't know. So that's not the general experience. And if you look at Joe Aboud, who writes a lot about this and is a consultant for that company, it has wonderful outcomes. But it's a very mixed picture if you're talking about that. And there was a Lancet study published, large multi-center study published in Lancet, my opinion of which was poorly done because it didn't really align all of the people investigating. And I got the distinct feeling it wanted to prove failure. That's exactly the opposite of so many other studies. So that's what I think about the balloon. If it didn't cost so much, I'd use it more. Because my hospital doesn't want me to use it, okay? Now that's before we get to the other things like SCR and everything else.
What would be your indications to use if you could, if it weren't cost prohibitive? What procedure would you replace with the balloon?
So the balloon takes about 15, 20, maybe less minutes to insert. So if you take an individual that's older, that doesn't want a big surgery and a long recovery, you're in a sling for a day or so. Start to use your arm. So who wouldn't want that? And one of my good colleagues, I'm not going to use his name, who has no conflict whatsoever and is very open-minded, shared with me that he did, of the first 9 cases he did, that he followed at least a year, 8 were fantastic and 1 failed. Mm-hmm. So, I don't have that series to tell you that. So whatever, it's a wonderful experience for recovery. When you start talking about SCR or tendon transfer or whatever, that is a long, arduous process of recovery. Mm-hmm. And the balloon, just pop it in and start to move your arm right away. So, I would have a lower threshold to use it on older individuals that didn't have very high demands, but had pain principally and maybe some weakness, not pseudoparalysis, but weakness. Must not include a tendon must not include a subscapularis tendon tear. It must be only the superior cuff.
The word Latarjet. Can you explain what that is to the listeners? And you've talked about this. I remember talking to you 15, 20 years ago about this. We had an athlete that actually needed the procedure. When is this a discussion with somebody who has a traumatic injury?
So let me first start by saying, for an additional reference, go to Boston Shoulder Institute. Just Google it. Then if you go to patients and modules and instability treatment, it will tell you who Latarjet was, what the operation is, with all of the with a number of articles about how well it works and my personal experience. And Sir Blundell Bankart, who is the father of the Bankart repair, which is, most people know, that's repair of the labrum. Okay? You can't really contrast them because the patients tend to be somewhat different, although not always. Latarjet was a French surgeon. Bristow was, I think, a British surgeon. Helfet was, I think, might have been South African, I'm not sure. They all describe transferring part of the coracoid process to the anterior part of the scapula adjacent to the glenoid to function by creating a bony extension of the glenoid when there was bone loss, but also a soft tissue solution with a dynamic sling created. So when I put the arm up in abduction like this, the ligaments that were incompetent had something substituting for that. Now, they're not all the same. So if we just stick with Latarjet, which is what I do, let me give you a little bit of background as to why one might consider it and then how it works. Number one, if you look in the literature of adolescent athletes, okay, and instability surgery, the recurrence rate after a Bankart repair in an adolescent athlete who's very active is double digits. Okay, it's not 2-3%. Article after article shows it can push 20%. Okay, especially in chronic Bankart lesions. In fact, we published years ago on chronic Bankart lesions, otherwise known as ALPS lesions or anterior labral periosteal sleeve avulsion injuries, and the recurrence rate with a 3-year minimum follow-up was 18%. This was in adults, compared to a recurrence rate of a more acute Bankart lesions, or at least Bankart lesions where the tissue was good, of 7%. Okay, not controlled study, but nonetheless, along with that, if you're a contact athlete and you have an instability episode more than once or twice, and you have a Bankart repair, and you're going to go back and play high-level basketball or high-level football or rugby, God forbid, or wrestling, the chance of a recurrence is super high. Now you get into minimum bone loss and more significant bone loss and all of that stuff, and there's a whole bunch of biomechanical data that shows that a Bankart is very ill-suited. Now, some people believe that doing a so-called remplissage, which is sewing the posterior rotator cuff into the Hill-Sachs lesion when you do a Bankart repair, will reduce that recurrence of instability. It doesn't make a lot of sense to me because the original the original report on this, published in the instructional course lectures 3-4 decades ago, was by Connolly. This was a Connolly procedure. And that was never published in peer review. Then Jean Wolfe came up with remplissage, which is the French word for to fill, since he went to medical school in France. And that caught on, and that's the latest rage with arthroscopic surgeons and all of that. And, you know, my confirmation bias is I see them and I've revised them to Latarjets anyway. Okay. So that's kind of an overview there. Now, very important, my practice is much more revision of instability surgery than primary instability surgery. So, of course, in that setting, we already know that revision of a failed Bankart with another Bankart has a very high recurrence rate. So for me, my procedure of choice is Latarjet. Now, if you look at the recovery of a Latarjet and a arthroscopic Bankart, they're virtually the same. If you look at the magnitude of pain, they are the same. We did that study. The major difference between a Bankart repair arthroscopically and a Latarjet is that a Bankart repair, the largest risk is a failure, and a Latarjet, the largest risk is a complication. And the complications, while they're rare, do happen, which I can get into if you want. But Latarjets are crystal clear, more reliable for instability treatment. And one of the best studies done was published by Gerber in the Journal of Bone and Joint Surgery, looking at long-term outcome of pain and recurrence of instability. And hands down, Latarjet was better than Bankart repair in his hands. And because arthroscopists love to do arthroscopy, and maybe hear some of this, there are a number of arthroscopic surgeons out there using arthroscopic techniques to do a Latarjet, though it has a significant learning curve and frankly doesn't seem to have major benefits over doing it open anyway. Sorry, that's a lot about Latarjet, but that's one thing your viewers should know is that if we do a Latarjet, the initial therapy program is passive range of motion by the therapist starting week 1. If we do a Bankart, you're in a sling for 4 weeks. If you follow it out a year, there's really no difference except for the recurrence rate. But you wouldn't start movement right away with a Bankart repair because the tissue isn't that strong, where Latarjet is very strong.
So you're seeing a better outcome overall if you had to choose one over the other. Latarjet better outcome with
Well,
reoccurrence rate.
yeah, the only indication for me to do a Bankart repair is somebody who hasn't had a lot of episodes, doesn't have demonstrable bone loss or a chronic lesion on a CT arthrogram or an MRI arthrogram, and understands that collision and contact sports are higher risk. Okay, then I'll do it. But again, most of the people I'm getting have already failed the Bankart repair, and that's an easy one.
Well, I was going to add, I mean, since your practice has selection bias for revision instability procedures, I think for the surgeon who sees the primary unstable patient, they're probably using some form of the instability severity index and looking at the patient age. And, again, that's why I bring that up.
Instability severity index score was developed by Pascal Boileau, a French surgeon working in Nice, and there's a bunch of characteristics for it. Christian Gerber once debated him at the International Advanced Shoulder Arthroscopy course in Val d'Isere and said, I would never use a classification scoring system that has the initials of ICE. Okay? You know what ICE is. So, and to be fair, the threshold for not doing a Bankart has gone down and down and down and down because the initial instability severity index score was too optimistic. And then Pascal started adding in remplissage, and then now certainly does his version of Latarjet arthroscopically. So I don't use it that much. By the time I'm using it, you're looking at bone loss and you're looking at a whole bunch of other factors that automatically lead me to a Latarjet anyway.
Can we jump to labral repairs? I think correct.
Because posterior is a different animal than.
Yeah, and we see a lot of we'll see posteriors with offensive linemen, defensive linemen when they get hit. That's where we see those posterior traumas. But I think the main one that we see is more the slap, where people complain they're symptomatic but they're functional. And dealing with adolescent athletes, is there ever a conversation there with those athletes that tear? What do you do with it?
So, first of all, the biomechanics of the shoulder. The biceps mostly functions at the elbow and flexion. The only time it functions in the shoulder is if you're throwing something and your biceps is contracting. And when the biceps contracts and adds force to the labrum, it increases the torsional stability of the glenohumeral joint and reduces the strain in the ligaments of the anterior capsule. That was a biomechanical study done many years ago at the University of Pittsburgh in the lab that I worked in by people before me, and there have been others that have replicated that. For the vast majority of people, the biceps is not a necessary component for shoulder function. And one of the most famous examples of that is John Elway. And in the year that John Elway was the MVP in the Super Bowl and won the Super Bowl, he ruptured his biceps tendon and it wasn't fixed. And he said, if I knew how good I'd feel after it ruptured, I would have had someone cut it sooner. So I just want to dispel the idea that, we better fix it because it's so important. The other thing that we know is that if you look at an MRI, there are many false positives as to superior labral pathology. As we get older, the labrum degenerates. Is it pathological or isn't it? And especially in people playing baseball, you see slap lesions all the time that you wouldn't want to operate on. So when is it really symptomatic? Well, I had a fall, it hurts me, I've positive findings. Either O'Brien's sign, which Steve O'Brien described, which is, in my experience, nowhere near as specific as it is sensitive. And, and an obvious MRI, preferably MRI arthrogram that shows a labrum tear. So that's the first thing. The second thing is there have been a number of articles on the role of physiotherapy to make people feel better. There's one from Columbia that I don't know why they had MRI showing so-called slap lesions, which may or may not have been slap lesions. People did therapy and many got better. That said, there was a huge run on slap repairs a decade and a half or more ago. And when I learned about fixing these, it was at the time when Herbert Resch, who's a Austrian, very famous Austrian shoulder surgeon, now retired, had tried to figure out how he was going to fix slap repairs using something called a SureTack device, which Russ Warren developed. It was a little tack you put into the labrum because we didn't have sutures and anchors and all of that. Herbert couldn't get the angle exactly right. And so he would drill through the acromion and put the tack in. And I remember when I was a fellow with Russ Warren, I said, look, we can just look at the spinal needle here. And some acromions, they're not that lateral. You can get a good angle on the superior labrum and fix the superior labrum. And then others had done it through the rotator, etc. It doesn't matter. Once we developed the skills to do it, and once we had anchors and sutures and the tools to pass these, boom, everybody's off to the races fixing all of these things. And it was wonderful until we started measuring outcomes. And if you look on the Boston Shoulder Institute under biceps and slap lesions, you go to the very bottom, you'll see about 10 years of experience with slap lesions and repairs versus tenodeses. And you'll see the repairs went like this, and the tenodeses went like this because the repairs didn't work so well. And I think it was Matt Provencher who published a series on Navy SEALs where the failure rate was like pushing 40%.
Mm-hmm.
So it's very rare for me to repair a superior labrum tear unless someone's a teenager, and they have really good quality tissue, etc. The vast majority of my patients, I'm doing an arthroscopic biceps tenodesis because when you detach the biceps from the labrum, it's not symptomatic anymore. And a tenodesis is very effective at taking away pain, especially if you have associated tendonitis of the biceps. And the recovery is much faster anyway. So slap repairs have largely receded in large measure. Now, one other thing I'll point out to you that was fascinating is some years ago, I'm trying to remember who did it. It was a surgeon that looked at the board submissions of cases for shoulder specialists to see slap repairs and how many were being done and the age category. And the age category went up, believe it or not, to 90. From like 15 to 90 to show you how crazy it was. The mania for slap repairs. Now, if you looked at it, I think you'll find slap repairs are relatively rare nowadays, at least unless I missed something. I think that's the trend.
Yeah, and I'm glad you went down the road of the tenodesis because we know that if you don't do anything, if we wait, do therapy, and the pain will get better as we get stronger and more stable, then that hopefully the symptoms will go away and you'll feel better in 6 months. But we've had people too that come in, the tenodesis just, relieves that symptom and you're fully functional and no issue, right?
Yeah, just while we're on the subject, tenodesis, there's about 100 ways to do a tenodesis. And just ask any surgeon, their way is the best. So you can do tenodesis above the pectoralis insertion, below the pectoralis insertion, open subpectoral, arthroscopic in the groove, with an interference screw, without an interference screw, blah, 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 etc. The vast majority work very well. Not always, but generally work very well. My preference, since I learned to do it, is to do suprapectoral, above the pectoralis, expose the bicipital groove, and it's super easy to do it. Whether you use sutures and an anchor, or I don't really like interference screws for a variety of reasons, but many, many ways to do it. And I think Steve Burkhart popularized this more than anyone else.
Are you doing that? You're doing that arthroscopically?
Yeah, I do it arthroscopically.
Suprapec, yep.
Cam, any input on like Major League Baseball?
So I think if you decide to operate on a slap lesion, a very symptomatic patient has failed conservative treatment and they're a major league thrower, I think, and I'd have to double check my literature, but I think the return to play after biceps tenodesis is actually lower than it should be.
Probably depends on the position, Cam, don't you think?
I think you're correct. But for pitchers, I think the return to play, so compared to your typical, non-Major League Baseball pitcher, is quite low, even though it may relieve their symptoms and sort of solve their pain and inconvenience issue. Getting back to pitching at a major league level, I think, is much lower.
I get to see them after that's over. That career is over, and now they have pain and their biceps hurts or whatever.
Mm-hmm. Yeah.
That said, remember what I said, mechanics, if you're throwing a fastball, the biceps transmits a force which increases stability of the shoulder and unloads the ligaments. So it does have a major function in those individuals.
Let me ask you this question. Swimmers, I feel like they're a bilateral pitcher. Do you ever see swimmers that have gone through the collegiate or professional ranks of swimming that have come to you with, bilateral, labral pathology or bony breakdown?
Yeah, but now we're in a different category. And to be fair, I took care of the varsity swim team at University of Pittsburgh when I was there. And I didn't see a lot because they didn't get far downstream with these problems. although I think it might have been Rowdy Gaines. I don't want to throw it in. I just heard it. I don't know if that's correct, but there have been some elite level swimmers that had posterior instability that still were very effective in their swimming because they were just so strong. And swimming loose ligaments in swimmers is nothing unexpected. It's just the muscles are so dynamically capable. Now it's very different than throwing. When you accelerate from max cocking position into a pitch, you can get up to 6,000 degrees per second force. But a swimmer is different. A swimmer uses their hand to pull themselves through the water at a much lower force rate repetitively over and over again. And swimmers, in my experience, may get some posterior instability, but they get scapular problems. And the reason for that was, you probably know this, Jacqueline Perry was a famous physiotherapist, biomechanical engineer, who studied the electrical activities of the shoulder girdle and identified that in swimmers who develop shoulder pain, the first thing that happens is that the serratus anterior fatigues, and then they get winging as a component, dynamic winging as a component of their fatigue, and that results in all sorts of glenohumeral problems, including superior labrum tears, etc. So remember, the shoulder girdle is not one joint, and these intercalated joints that work in series require proper coordinated motion. And so I like to say that the scapula, Bassam calls it the house of the shoulder. I'd say more, it's the core of the shoulder. You know how we work on our core? A good thrower has to have a good core. It's from the ground up, right? Well, a swimmer has to have a good core of their scapular muscles. And swimmers are notorious for not strengthening their external rotators or their scapular muscles, only the muscles that pull through like this. And they get all sorts of overuse injuries that get diagnosed like slap lesions that have surgery that really probably don't need to be done, that could have been avoided if they did the right physiotherapy program for the axioscapular muscles. To be fair, not all physiotherapists understand that at all.
Yeah, I actually had a conversation with a swimmer a couple of weeks ago. We had just finished the swim season. Girls ended up winning the state championship. I was talking to an athlete, the same thing, that, your weak serratus, winging scapula, tipping, upward rotation, which is causing impingement. And, if we addressed this 3 months ago, you wouldn't have had this. Well, she said, I didn't think I had a problem. I felt fine. But we see it all the time because we have such a big dynamic swim program.
Yeah.
But that's 100%.
There are a lot of preventative things to do in swimming, including core work on the scapular stabilizers as a preventative measure, which a lot of swimmers don't understand to do, including limited use of hand paddles and pull buoys, particularly when you're having pain, including watching your mechanics so that somebody's paying attention to when your mechanics are failing, including body roll, including how far out you're catching in the water versus, all those sorts of things transmit more and more loads across the scapula that fatigue it. And ultimately, they come to you after they've already deteriorated in their mechanics.
Yeah, and we'll find that some people will be more symptomatic, if they're turning more, head breathing one side versus the other, if they don't alternate, and we'll see that in their upper trapezius and their scapula. So when do you talk about biologics? Like, I know him and I were talking about it. So when does that ever come into a conversation? I know Cam's laughing because he wanted, I think, talk about it.
Patients ask me, okay? So when you say biologics, let's define what you're talking about. I mean, PRP would be one. Stem cells would be another. Cam, is there something else I'm missing here other than those two things?
Biologic healing augmentation for rotator cuff repair.
Let's get the injectables off the table, first of all.
Okay.
So again, I'm not an expert on this, and most of the published articles about this have an inherent conflict of interest and self-affirmation of the people publishing it, generally because most of these are not paid for by the insurance company, and so patients become a walking ATM machine. Okay?
Yeah, that's right.
And so let's go to stem cells first. So if you talk about stem cells, there's relatively little evidence for taking stem cells, spinning them down, and injecting them into the shoulder to eliminate pain associated with impingement or arthritis or things that people will often try to get injected for. And there have been a number of studies from HSS and other places that looked at it in rotator cuff repair, et cetera, and didn't find it to be particularly helpful. There are many different preparations, and there are companies that create and sell the tools to do this. And a lot of it is driven by pro athletes that had injection of PRP and feel so much better and look, they're competing, and yada, yada, yada. But there may be a lot of other factors, not the least of which is the money at stake.
Mm-hmm.
So people want that. And I don't see enough evidence in it to say that it's a great thing to do. Moreover, there are prospective randomized studies that have demonstrated no difference from cortisone, from cortisone injection. That said, there are companies that spin down your own fat, and then give it to you as an injection. Now, the FDA, if I understand correctly, doesn't regulate this because it's your own tissue.
Mm-hmm.
So spinning it down and giving it back to you, it's not a foreign substance or structure or something like that. Okay? So for me personally, I get people after they failed, and I'm not generally putting it on my list of things to do because it doesn't meet the qualification for burden of evidence, at least for me. Even in my own organization, people do PRP injections, and if there's some overwhelming data that I'm missing, I welcome anybody to send it to me. I might change my tune, but that's what I've seen so far. The other part of it, Cam, which you talk about, which is biologics. Those are the things that, remember I said, rotator cuff repair ranges in our institution from up to 7-8 times cost, from the lowest cost to the highest cost. Well, those biologics are the major drivers, all right? And again, the evidence in support of, I won't use brand names, but tissues that are used, well, and superior capsular reconstruction and other things, isn't that strong. And there was a huge drive towards SCR, for example, superior capsular reconstruction. Again, it followed Scott's parabola. It went up, went down. And that's a published article, not my work.
Mm-hmm.
Our experience here maybe reflected how bad we were as surgeons, because the guy that popularized this didn't like me for publishing it. We had like failure of everything. And we looked at learning curves. So the guy who did the most of these, we published this in, I think, Journal Shoulder Elbow. The guy who did the most superior capsular reconstructions, in his first 10, his failure rate was 60%. And then the next 10, it was 40%. Those were just failures that had evidence for failure. The people might have been complaining, but they hadn't yet had a surgery or something else, or MRI documenting their failure. And I may be wrong. One of the champions of this, Pat Denard, I don't think is doing that anymore. I may be, that's just my understanding. I may be incorrect. And so now people are trying to crush the biceps and use that as an autogenous graft and all sorts of other things. Anything to avoid not repairing something or doing, God forbid, something else that might work, which we can get to in a minute. Now, there are novel technologies. I don't want to talk about them, one of which I'm conflicted with. Specifically, don't want to talk about that, but there act as scaffolds that add inherent strength to unload the rotator cuff while it heals, and may be a lattice onto which collagen fibers may intersperse and grow. There's still not sufficient evidence for these things yet, and they're going to start, well, they're being used, but one in particular is going to start being used in the U.S. We'll see. At the end of the day, if the evidence supports it, everybody may run to it. But these require the muscle not to be stage 3 or 4 fatty atrophy. There has to be a dynamic connector. SCR was just basically a static thing that you sewed from the glenoid rim to the humeral head, and above the few degrees of abduction, I don't know what kind of role it really would play, except maybe transmitting force to what remained of the rotator cuff. So that's kind of my answer about biologics and grafts and things of that nature. And again, I may not be the most informed, but I get to see all the failures, so that's my confirmation bias.
I think that's a great explanation there, because I think people just hear that and they just don't know what does that mean, And I think that's a really good explanation as to why. I think Cam had a question on TSA and indications.
I promise I'll get to an important area, and that's tendon transfer. I want to give a shout out to Bassem El-Hassan, who was my former student and the person I hired to take my job. In terms of pioneering this. We've known about tendon transfers for years. I learned latissimus dorsi transfer for irreparable rotator cuff tears from Christian Gerber. I've been doing that for 3 decades now before Bassem came up with alternatives. I can tell you, not long ago, I saw an international patient on the other side of the world, 7 years after I did his tendon transfer, and he plays polo 3 days per week. So these things work. They're dynamic solutions when the rotator cuff dynamics fail. So we have tendon transfers for the front. We have tendon transfers for the back. They're dynamic. There are a lot of articles about it. They make inherent sense because they take a dynamic structure, the rotator cuff, which no longer works, and substitute a dynamic solution, which none of the other things we've been talking about do. And while they're not perfect, I think our latest article was published on 60 or 70 cases we did of something called lower trapezius tendon transfer. And something like 85% of patients at 1 year said they were happy they did it, would do it again because they felt dramatically better and had better function. So I don't want to leave this topic without saying there is an alternative here. I don't have any that I can think of any particular conflict with tendon transfers of a financial nature, other than just my opinion that it's a better solution than some of the options.
And I have to say firsthand, I have a really close friend of mine that had 2 cuff repairs that failed, and he was going down the road of total reverse shoulders. And actually, Dr. Warner, you saw him, did a lower trapezius transfer. He would have been going down the wrong road if he had a total reverse, and he's happy he made that decision.
Well, I guess we can piggyback on that. What do you think of the expanding indications for reverse shoulder arthroplasty and the relatively narrowing indications for anatomic shoulder arthroplasty?
Let me briefly give some history here because people don't understand. It was Paul Grammont in France who created the Grammont prosthesis, otherwise known as the Delta prosthesis, which was first marketed in the United States by DePuy J&J in 2004. And it's since been modified by every single company has made their version modification, etc. Reverse was originally indicated for irreparable rotator cuff tears and has since been indicated for arthritic conditions with severe deformity of the glenoid, for failed arthroplasties, for fractures, for many, many things. So it has, let me put it this way. When I asked the members of the Codman Shoulder Society, a large group of experts, please rank for me the most innovative things that have happened in the last 50 years in shoulder surgery, and you looked at the weighted rankings, reverse replacement was number 1. Okay? So I think it's been incredible. However, like most things, there's always overexuberance and inappropriate use. So you'll find people that are weak, or maybe they can raise their arm, but they have terrible pain and they have a massive rotator cuff tear, and they'll get a reverse when a tendon transfer might have been just as good and they keep their own joint. Okay? The other area is using it in arthritis, which is not a topic we've been focusing on, but there's no question in my mind it's overused. And the Australian National Registry clearly shows that in a large data set analysis, reverse has more durability over time than total shoulder replacement. However, they're comparing apples and oranges when they're looking at the two of these. And some people will put reverse in and say, well, the patient's too old and they might tear their rotator cuff, so we better do a reverse when they have no significant deformity of the glenoid and no major significant tear of the rotator cuff. When in fact, older individuals have greater durability of the outcome of arthroplasty, anatomical shoulder replacement, than younger individuals, particularly males, who are going to load it and do heavy load things. So it's a wonderful operation. The other day, I saw a woman 17 years out from her reverse replacement. The second reverse replacement approved in the United States after the Delta from DePuy J&J was the anatomical reverse, or called inverse, from Sulzer, which really became Centerpulse, which became Zimmer. And that was a design that Christian Gerber created and I helped him with. And I don't want to get into too many technical elements of it, but this was a 90-year-old woman who 17 years ago I operated on, who drove herself to my office and lives independently, reports her shoulder is 100% of normal. And if you looked at her motion, not even you, Riz, would have any idea she had a reverse because she could instantly rotate the T10.
Yeah, that's amazing.
So that makes you very excited about using it on everybody. But like most things, generally you wouldn't start at the beginning of a meal with ice cream. That would come at the end.
Right. For some of us.
For some of us. Same with the reverse. It's seductive, okay? But it is certainly misused from time to time. And revision of reverse to reverse is not a lot of fun.
Yeah, I'm sure. Hopefully I don't need one ever.
Well, if you are, you're older, and then, you're not so active anymore, and you just want to be out of pain and use your arm to bring food to your mouth and sleep at night. And
that's it, which is good. Dr. Warner, if somebody doesn't have a great outcome with their shoulder and they want to come see you, how do they get in touch with you? What's the best way for somebody that's listening or watching to get in touch with you or your team?
Sure. Go to Boston Shoulder Institute. That's one way. you can Google me and you'll find a link to the Mass General. And I think our direct numbers are there for my staff to contact my office for, and I don't need more patients, but just to say that I work.
You're winding down, I heard. Yeah, you're winding down.
It fluctuates. My office is in Waltham at MGH West. I don't work at the Mass General anymore. I gave my office away to Dr. El-Hassan, and I like to live closer to home. Plus, I work there and at Newton Wellesley Hospital. And so you'd find me at MGH West as well. So it's not too hard to find people these days.
Yeah.
Boston Shoulder Institute would probably be the best way, or just Google me and look at Mass General. You'll find me.
And like you said earlier, I think for people listening, there's a plethora of information on Dr. Warner's website that you can get information on any type of shoulder pathology from what I can remember.
Not all, but, and to be fair, because it was bootstrapped and done some years ago, it's not exactly up to date, but pathology doesn't change.
No.
So the way we explain to people what their problem is one thing. Some of the solutions have nuances or some significant changes. So we don't have things like in-space balloon isn't there, and more modern tendon transfer things are not there. We'll maybe work on the next version of it to support Dr. El-Hassan and his team. And just a shout out for the shoulder service at MGH. The shoulder service is a large group now that is a referral practice that is basically a solution for all New England and, frankly, domestic tourism and international tourism for failed procedures and procedures that are very, problems that are very difficult to solve. And Dr. El-Hassan and team are as skilled as anyone in the world in solving those problems. So people who may be listening to this, don't lose hope. Dr. El-Hassan is basically a Pac-Man for revising complex problems and making people happy. And has been known from time to time to actually dance with his patients in the recovery room after their nerve block and when they don't have pain, because everybody's so excited about the outcome, the potential outcome of the surgery he did.
Yeah, that's great. I'm glad that the service keeps expanding. Before we end our discussion, what's a fun fact about Dr. Warner outside of you being like this? I would say apex predator, but I don't know if that's the right word. I think
there are two fun facts I would say, and I think this may resonate with some people. It's not how you start; it's how you finish. Okay,
that's true.
So when I started as a little kid, when I was growing up and I was in second grade, nobody knew what dyslexia was. And I had a mother who was a member of Mensa, which is an organization for individuals who have an IQ in the top, 3% or something. Something like my mom's IQ was like 165 or something when they measured IQs. And because I had dyslexia, didn't know what it was, and maybe a little bit of ADD, I failed second grade. Einstein did that, I think, in sixth grade. I'm no Einstein. And actually they called my mom and said to her, John isn't really reading and paying attention and this and that. And we were giving him an IQ test because he wouldn't really participate. We gave him a 0. So I'm probably the only professor at Harvard that has an official 0 IQ somewhere. Okay. The other fun fact is that the second part of my careers have 2 parts if you're lucky. And, I think my enthusiasm isn't just taking care of patients. That's there for sure. But I went to business school and I became an entrepreneur, and that's been the most fun thing I've ever done, because it's not just to make money, but creating value out of nothing or out of something that changes something is the greatest feeling ever, other than having children. And so, for example, Orthospace, that was a smaller one, but we had a company named Imascap that was bought by Wright Medical, that it was the first automated digital planning tool for shoulder arthroplasty that now is called Blueprint and forms the digital platform for robotics, for Stryker, and et cetera. That was incredible. And a number of other things. ViewMedi, for example, one of the first companies I ever got involved with that now influences not just orthopedic surgeons, but physicians all over the world. So from someone who had a 0 IQ and failed second grade to someone who went to business school and then where I am now, I'm very proud of what I've been able to do, despite the fact that I started out really as a ne'er-do-well and an unaccomplished individual, and still managed to succeed in some level that my children sometimes look at me and say, not bad.
Yeah, that's good. Well, I have to say, I truly value you as a surgeon, but also as I feel like you're a peer, a colleague that I can turn to and I can actually direct patients to. So I do value that. And I appreciate your time today coming on and taking time out of your day. And I think, as Cam said, having you as a mentor has been great for me, learning from you and then helping to direct my patients for better outcomes. So I appreciate it. Thank you.
My pleasure. Thanks for having me.
Yeah, I appreciate it. It's been a lot of fun.
Thank you for tuning in to the Behind the Sports Medicine podcast, proudly sponsored by AJR Sports Science and Healthcare Consulting. At AJR, we're committed to offering a comprehensive range of exceptional services, including applied sports science analytics, healthcare and sports medicine consulting, and leadership and coaching development. To learn more about AJR, visit their website at ajrsportscience.com. This is your host, Andrew Rizza.
And I'm your co-host, Cameron Roth.
If you enjoyed the content from today's episode, give us a like, leave a comment, and share on social media. You can find all of our episodes on Apple, Spotify, or wherever you listen to your podcasts. You can also follow us on Instagram at Behind Sports Med Podcast, on X at AJR Sports Sci, or check out our websites at ajrsportscience.podbean.com and at ajrsportscience.com. You can also subscribe to our YouTube channel at AJR Sports Science. Stay tuned for our next episode.